practice. The talk today is going to be given by Professor Dr. Noor Aisha binti Mohammed Taib. And this has been a very useful topic, especially for general practitioners, because day in and day out, we do get patients who come in and request for tumor markers to be done along with the regular uh, blood screening and urine screening tests. Okay. Okay. Before I go on to Prof. Noor Aisha's CV, I just want to have a few housekeeping rules. Uh, please mute the mic, all of you, the participants, and any questions, please put in the chat box, and we will be able to, at the end of the session, we will be discussing the question and answers, the Q&A sessions, basically. And at the end of the session, there'll be a QR code which will be displayed, and you'll be able to claim your CME points. Okay, so I think the housekeeping rules are quite straightforward and nothing different from the other, what do you call, Zoom meets and all that. Okay, we are very delighted to have Prof. Noor Aisha and MAG, the Marpati Alliance Group, as well as MHSB, Marpati Health Services Berhad, the business arm of MAG. We are proud to liaise with and Project ECO to have this wonderful evening CME session. Okay, and just a brief thing about MAG. MAG is a coalition which was established in October 2024 of dedicated doctors to foster professional collaboration and mutual support and excellence in patient care. It also addresses issues faced by GPs in Malaysia and aim to facilitate or mitigate the said issues, whatever issues which was at hand. MHSB was a business arm, and as a Berhad company, MHSB allows clinic owners to become shareholders. And this inclusive approach basically strengthens the unity and provides a shared platform for advancing collective interests. So this is an ecosystem which is built basically by doctors, for the benefit of the doctors, especially the GPs, the general practitioners. With so many issues in hand for the general practitioners now, I think it was something, this MAG and MHSB became such an important point of it that so many GPs and doctors joined this particular group very fast and very effective. As we know today, we have around 1,200 clinics have joined MAG, and we are proud that we are just going soaring very high in this, and more doctors are joining. More requests are coming from Sabah and Sarawak as well. So this is a short intro basically on MAG and MHSB, and we would also basically request all the doctors, also those who have not joined, to tell their friends to join this group. It's as of now, it's completely free. There's no joining fee or subscription fee, and whatever we are doing, like recently we had what do you call the pharmaceutical company, wherein we were able to get things done, okay, at a price which is very, very feasible for all of us, and the clinic system, and so on and so forth. Okay, I do not want to go much into this, and I think we would go on to the next thing. Basically, I would like to talk about the VIP of the day, Dr. Noor Aisha Mohammed Taib. She is a senior consultant breast surgeon. She was an associate prof in 2009 and professor in the Department of Surgery, University of Malaya from 2012 until 2025. She has since retired in September 2025 and still volunteers to mentor students and lecturers in She is currently practicing at Specialist Center and Beacon Hospital in PJ. Graduated both her undergraduate as well as the master's from her famous alma mater, University of Malaya. She did a sabbatical in Hospital Putrajaya and clinical observation in University of Wisconsin, Madison, and MD Anderson Cancer Center in 2008-2009. Postgrad diploma in genetic counseling from Charleston University in 2010. Doctoral degree, Doctor of Medicine from in 2011, entitled Why Women Present with Advanced Breast Cancer, a Mixed Method Study. She's a member of the National Committee of Breast and Endocrine Surgery Specialist Evaluation, Malaysian Medical Council, chairperson and founder member of Breast Chapter of the College of Surgeons of Malaysia 2015 to 2000, fellow of the Malaysian Academy of Medicine since 2016, and a past honorary treasurer and a council member of the College of Surgeons of Malaysia 2015 to 2019, a council member of Breast Surgery International 2017 to 2024. Lots of laurels, Prof. And not only this, Prof. Noor Aisha is trained with a Master of Surgery in Malaysia and on board of examiners for exit visit for the breast endocrine surgery subspecialty exams in Malaysia.
You need to read
She's
everything,
also
Dr. Garrison. Too
she's
long.
also principal investigator of
Summary.
Rebunk. Okay, Prof. Just a
Kan,
bit more.
apa?
I'm just highlighting the important ones only.
Okay.
Reducing barriers in cancer early diagnosis in urban B40 group, a cancer early diagnosis ecosystem implementation study piloted in PJ funded by UN. And she's got a very a long contribution to the country as well. The online Rebound Cancer Care and Primary Care course won the Open Learning Global Innovation Award in 2023. And she's active in advocacy and it's president of Together Against Cancer 2023 to 2025, a Malaysian NGO. There's a lot more actually to her CV, but what I would, I've just reduced it a bit, and it's still quite a bit of it. Okay, at this juncture, probably I will just pass the floor to Prof. Noor Aisha Mohammed Taib. The floor is yours, Prof. And we are very delighted to have you today here, and thank you for accepting MAJ's offer for this present CME online meeting. Thank you.
Thank you, Dr. Garrison. I think, Dr. Garrison, you were going to tell us a little bit about the scenarios you all face in the general practice, and specifically on cancer screening. Would you like to maybe give some background about why I think MAG, I think it's a very important topic, and why is it that you all find this extremely useful to sort of inform your practice?
Definitely, Prof. Actually, I could give a list, maybe a couple of real scenarios which happened in my clinic. This was probably around 12 to 13 years back in Muthiara Damansara, when I had a person from UK, basically, a Matsale, basically, he came in and then he wanted to do a regular blood test screening. And we did a blood screening, but he was saying that he had some urinary issues. He had some urgency and hesitancy when he passes urine. So he just wanted to check on his prostate as well. So it was basically a screening test. We did a PSA, and his PSA levels were very high, actually. And I was a bit surprised his levels were quite high. And so then I referred him to a urologist in Subangja Medical Center, where it was confirmed he basically had cancer of the prostate. Luckily, we were able to identify it much earlier. And he was around 52 to 53 years at that moment. And that was a very important step for us. We did the tumor mark and we were able to catch it much early. And then he went on to proceed to Boston in US, where he had a friend who was basically a urologist who did a robotic surgery on him. That's a real-time scenario which I had in my clinic. And also we had recently, there was one 35, 36-year-old a lady who came into my clinic. She said had a family, had a history of diabetes. So she wanted to do basically a HbA1c and a random blood sugar. And then suddenly she remembered and she said, Doc, can you do also CA 15-3? I'm just worried because there is a family history of cancer in the family. So she said, could you also do a CA 15.3? So we did that. Fortunately, the thing came back as negative 15, CA 15.3 was basically normal for her. And then we continued with the rest of the investigations, and she was okay, she's normal. And so there are two different scenarios, wherein one was actually we managed to catch early the PSA, and the second scenario is wherein this lady was a bit worried because of the family history, and CA 15.3 was done, and she was basically normal. And these are the two scenarios, Prof. Maybe you could just go on your views whether how good this tumor markers will help in a GP practice. Thank you.
Okay, thank you, Dr. Ganison. And also thank you to Dr. Nasir for inviting me to give this very important talk. I hope that, the talk is actually very simple, but I thought that I would share maybe some principles because as we know, cancer is the most is the third cause of death now in Malaysia if you aggregate all the cancers together. So we need to really focus on how we can reduce morbidity as well as mortality from cancer. We know that our cancer stage at diagnosis is extremely delayed in the sense that a lot of our cancers present in very advanced stages. So, the commonest cancer we have is breast. The second is colorectal cancer, and the third is lung cancer. It used to be lung cancer was the second cancer, but now colorectal has actually overtaken lung cancer. So these are probably the three most important cancers that we should think about, especially in a GP practice. So what I will hopefully cover today is about cancer screening principles, differentiating between screening people who have no symptoms and people with symptoms. Because as we reflect back on the story that Dr. Garnison put in, the true screening patient is actually the woman who has a family history but does not have any symptoms or signs of breast cancer. But for the man who has the prostatism symptoms, he actually has symptoms. And therefore, this is a person who have symptoms. And therefore, we wouldn't classify him as to be done, for us to do screening, but it's more of a diagnostic process that we are aiming towards. Okay, then I will touch upon the tumor markers. Why is it important that we understand what tumor markers are? And I will touch a bit about emerging technologies because I think we're all faced with all kinds of technologies being put to our doorstep. Some fancy blood tests or some fancy machine that promises the future, the ultimate thing. All right. So we'll go a bit through that. And then, of course, we can discuss a little bit about clinical practice implication and what would be the Malaysian cancer screening recommendations at the moment. So, we all look for the perfect cancer screen. Actually, I pun tak tahu, this thing is called the medical scanner from Star Trek. Okay, I was not a Star Trek, I was not a Trekkie, but essentially we are looking for that ideal test that could actually produce something that is easy to do in the clinic, inexpensive, and it has a high positive and negative predictive value. That means very rarely we would overdiagnose or accidentally give a positive diagnosis when it's supposed to be negative, and a negative diagnosis when it is truly a cancer. It has to be inexpensive, it has to be simple, standardized, and automated with clearly defined reference limits, okay? And obviously the tumor marker has to be acceptable to subjects undergoing the test, and the clinical value has been validated in large prospective trials. Okay, so
Prof, sorry.
yeah. Uh-huh.
Can we put the slide on slideshow?
Oh, is it on the other one? Okay, let me
It's
swap.
yeah,
Is it
yeah,
better?
yeah.
Okay, thank you, Shaira. Thank you. Okay. All right. So the advantages of having this type of simple test, right? Okay. You can measure it with just blood or urine or something that is minimally inconveniencing to the patients. Okay. And then all these tests should have some sort of automated assays that's available and allowing to process large numbers of samples. Okay. And these tests for markers provide quantitative results with objective endpoints, okay? And these markers should be cheap and easy to do comparatively to radiological, histological, and endoscopic procedures, okay? So this test that we are talking about today is exactly this, isn't it? The tumor marker, okay? It's fast, it's easy. I put that easy money. for labs, okay? And the good thing about this, labs can run it on their own. They don't need expert consultations from their doctors, and they don't need any operator to actually do this test. So tumor markers fall into this category, unfortunately. So it's somehow come into the commercial window where lab actually recommends it and do it, I think, for the last probably 3 decades. All right. But if you think about it, are we really having the evidence-based type of evidence to support its use? So remember, this test has to be highly positive and highly negative predictive values. So you must have high sensitivity and very high specificity to actually make it an ideal tumor marker test for screening. Okay, so if you all remember, back in the 60s, okay, the original Wilson and Jungner criteria for screening. So there are 10 criteria, right? I'm not going to go into the details of this. And I think GPs, family medicine, actually, they are pros at this because this is exactly what you all do in your clinic when your patient has no problems, when you're trying to do preventive care. So would we say our tumor markers fall into this category? Okay. So of course, the health problem is important. Like most of the tumor markers mentioned just now, PSA, CA153, these are supposedly markers that will supposedly find our cancer patients at an early stage, right? It's an acceptable these cancers have curable, they are curable and they have curative treatments. Therefore, that's good. And the facilities for diagnosis and treatments are available. Okay. And we can recognize that they have a latent or early asymptomatic stage where there is no symptoms at all. So these are all suitable, right? And the test is acceptable and blah, 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 right? The natural history of the condition is known. And then, of course, we all have protocols that we have agreed upon on how to treat these patients. And the cost of case finding, including the diagnosis and treatments, is actually economically balanced. And then the continuing process can be done through a structured program. So, for example, you have usually an interval of a test that is done maybe every 2 years or every 5 years. Okay. So this test, every time we do a screening test, we must remember we must fulfill all these criteria. So now, what are the tumor markers? So I'm sure by now the panel is a normal panel. I think probably some patients maybe have done this for decades, maybe 20 years of tumor markers, and they've been probably spending something like 600 ringgit per year, right? But did we really find the cancers? So then we have to talk about the limitations, right? So these markers do have the limitations for a screening test. In particularly, they lack the sensitivity for invasive cancer as well as pre-malignant cancers. And some of them lack specificity. And because of this dual problem, and of course, the prevalence of cancer in our country, even though we think it's very high, it is still lower than other developed nations. For example, the lifetime risk for breast cancer is about 1 in about 20 women in Malaysia, as compared to 1 in 10 in the UK, for example. Prevalence actually makes this test almost like uh it's like just throwing money lah, without getting anything in return, right? So therefore we have to think about biomarkers and how do we use them in a very evidence-based manner in our clinic. So I'd like to share with you a study that we did. Actually, the study is a very old study in 2008, where we actually we actually took the CA153 out of about 437 women before they had any forms of treatment. And so, you see, CA153 is used very commonly, as also mentioned by Dr. Ganison just now, because it's in the panel. So a lot of people use it to screen for breast cancer. So from this group of patients, you can see this little graphic up here, the little bar chart. You can see the stage 0, stage 1, stage 2A, 2B, 3A, 3B, and 4. The CA153 is mainly elevated in the late stages. You can see that in stage 0 and stage 1, none of the patient actually had a raised CA153. And then in very early stages, which is curable, like stage 2, 2A, 2B, and 3A, it is extremely low positive results. And you see in stage 3B and 4, then only you will find that the CA153 becomes abnormal. No doubt CA153 predicts outcomes quite well, but it is not a good screening tool. Okay, so a study that was done much later, okay, in the year 2023. Okay, this paper actually N is only equals 180, if I'm not mistaken. But you can look at the sensitivity of the test. And what they did was they put 5 tumor markers together, and they looked at the prevalence or the incidence of cancer in this group of patients. And they find that the sensitivity of picking up a cancer is actually extremely low, only about 20%. But the specificity is very high. So specificity is if you have a positive test, what is the rate of it really being positive? So it's actually a very good specificity, but not very good in picking up cases in the large population. So it's not sensitive to pick up cases in the community. So therefore, I think, I hope with this illustration for CA153, we can see that it is not a very good screening tool. It may be used for prognostication purposes, but even then, that is not used in the routine setting. So there's no real room for CA153 to be part of a screening test. Furthermore, some patients may actually be falsely positive. So we have had patients with raised CA153, which they present to the breast clinic and with usually mammogram and ultrasound already done, showing no disease in the breast. And we usually have to do further tests like MRI breast to just make sure there's nothing in the breast. And the unfortunate thing is these patients, even though all these tests are normal, they will have sleepless nights for at least 3 years because they really don't know whether they have something. Even with the conventional test that shows all negative results, they would have this harm. So this is what we call the harms of screening. All right. So why is it that tumor markers are not exactly the best of the test that we should do for screening? It's because it actually is a test of the antigens. So CA153, CEA, and so forth, they are actually antigens from the tumor. So they are not well in terms of the volume of the tumor markers it will be too little to be picked up in the serum. Okay, so nowadays we know that cancer expresses in different ways, right? There are abnormalities in the genes, in the proteins, right? In the transcriptome, the lipidome, metabolome, and all this metabolome. They call it the oh my goodness, metabolomics. All right. So there are many ways of detecting disease nowadays, and they even use infrared spectroscopy. So that's using like the wavelengths of light to look into the tissues or into the serum. So all these tests are currently being investigated and probably holds a bigger promise than just expecting a small volume disease to express its antigen, and therefore tumor markers and all these serum tumor markers are not exactly the best thing to do when you are trying to find small tumors. Okay, so just to share that, all these have been going on forever and ever. So probably the beginnings of identifying proteins that's associated with disease, right? So you can see that all these antigens were mainly done in the 70s and the 80s, right? And then by the early 2000s, it becomes a lab test with they have a reference values, right? But then I showed to you just now that the picking up early cancer with the tumor markers is extremely difficult and not really recommended. Okay, so I don't suggest you know exactly what all this is and in terms of which tumor and all that, because really it does not really help in detecting early cancer. So we have to go back to the conventional ways of detecting early cancers. So I wish that we had something like this in Malaysia, right? So like in the UK, they have this NHS population screening timeline to integrate all the disease together, because I think people don't understand the GPs and they don't understand primary care, our policymakers, because they seem to think we can have program breast cancer, program colorectal, program prostate cancer, and then expecting the implementers to know to be a specialist in all these areas and not giving them an integrated view of how we should screen our patients. So if you can see in the NHS, in terms of cancer, only 3 cancers actually is shown here. So cervical cancer screening, breast cancer screening, and bowel cancer screening. So that is how, I think the UK, they're very much into health economics, making sure that everything is done that has value is only then implemented. Okay, so how about Malaysia? So Malaysia, we do have clinical practice guidelines that clearly looks into certain diseases. So we do have guidelines for early detection of cervical cancer, breast cancer, and colorectal cancer. The other cancers, I think prostate cancer has recently produced their first guideline for screening. For lung cancer, there is no guideline policy-wise, except for, I think they have come up with this lung health initiative recently, but then again, it's not a clear national guideline in who we should be screening. Okay, and of course, you have heard about multi-cancer early detection, and this is usually done by a blood test looking into circulating DNA, and a lot of, I think, private sector may have actually jumped onto it, but you know that this is not approved as yet for routine clinical practice. So at the moment, we should not be using non-evidence-based screening tests. So I wouldn't suggest you get on the bandwagon with the multi-cancer early detection. So if you look at our general uh, recommended tests for Malaysia National Cancer Screening. So for cervical cancer, HPV DNA has actually now overtaken Pap smears. The beauty about HPV DNA testing is that the woman can actually self-test. So all the barriers related to having a examination, a vaginal examination, a Pap smear and all that is no longer a barrier really, because the woman can actually do her own self-testing. So I would also like to hear from you all later on about how you actually uptake HPV testing in your practice. Does the woman do it as self-testing, or do they still get the usual examination of the past? So the target population here is 30 to 65, and the beauty of HPV DNA is that it has a very good negative predictive value. So if it's negative, the test can be done every 5 years. As compared to cytology, when you're not sure that it's a year, then if it's negative, it's like 2 years. So it becomes very complicated. All right. So in 2023, they have actually moved on to HPV DNA, and the self-sampling is encouraged. For breast cancer, mammography and clinical breast examination is now in the policy for early detection of breast cancer. So there was a very large study that involved something like 30,000 women in India. And what they have found is that just by doing 2 yearly clinical breast examination after the age of 50 reduces the mortality from breast cancer. And now Malaysia has taken up the policy of providing clinical breast examination in the clinic kesihatan for women between 30 to 74. For mammogram, the is between 40 to 70, and for women with average risk, it would be every 2 years, right? Okay, for colorectal cancer, the third one is the fecal immuno test. which is looking at the fecal occult blood test, okay, and there is a thing called DNA fit, which is they did a pilot on it, but it is actually available in the market, I think now, and this is done for people between 50 to 75 years, and this is more on it is related to average risk, okay. If the patient is high risk, then only they will go on to colonoscopies and so forth. Okay, so it's done every year for the immuno or the fecal occult blood test. The other one, the DNA fit, is every 1 to 3 years. Okay. Don't forget, we actually have a very high hepatitis B in the population. So a lot of women, a lot of people actually have their hepatitis B tests done quite routinely nowadays. So if you have anyone with hepatitis or even cirrhosis, they should be offered ultrasound and AFP. And this is the only time where alpha fetoprotein, a tumor marker, is being offered within the screening. And you can do this every 6 months. Okay. For prostate cancer, PSA, they do put the screening between 50 to 69 every 2 years, but this is not a national program, and a shared decision approach need to be taken. And there is patients with high risk for prostate cancer. For example, people with breast, ovary, prostate, and pancreatic cancers in their family, they should do a more intensive screening with PSA and sometimes even rectal ultrasounds. They could be carriers of the BRCA gene. So if there are any worries about anyone with a strong family history, I would suggest a referral is made to specialists who deal with those types of cancers so that they can offer more intensive screening. All right. How about lung cancer? So lung cancer, again, I told you that in Malaysia, we don't actually have a national policy, but now we have this lung health initiative where they are trying to downstage our lung cancer. Because lung cancer, the patients are all diagnosed, 90% would be in stage 4 lung cancer when they are diagnosed. Okay. And people who are high-risk smokers can be offered low-dose CT on in a yearly manner. All right. So if anything you want to take back, this is probably the slide that would be something that you could use. So again, about molecular cancer screening, the only cancers that you could use this, and it's not just the blood test. Okay, we're talking about HPV DNA, as I mentioned just now, the sDNA fit test for the stool DNA in colorectal cancer. These are only the two things that probably has enough evidence for usage. Okay, the other one, the emerging test just now, I think it's best not to embark on that at the moment, because one thing, it may have that promise. Okay, we are waiting for the gallery trial in the UK to show us whether this is really useful. And guess what? The results is coming out next year. So we have time to actually have the evidence before we embark on this type of screening tools. So again, the 3 types of cancers that you can use some form of molecular testing and tumor markers is these 3. Okay. All right. Okay, I think I'm repeating this again. Don't forget, nowadays there's this thing about AI triaging, and you've heard probably about the Ministry of Health project where they're looking into AI-enabled chest X-ray reading for screening for lung cancer. So that is still, I think, more like a pilot rather than a policy. Okay, so again, our Star Trek. So we are trying to look for that elusive test that is easy, that is cheap, right? Even I think for the DNA tests, like the multi-genomic test, it will cost quite a bit, probably about close to 2,000 ringgit. And how to do that every year, right? Okay. All right, so this one is okay. So I think one of the things about clinical implication, I think somehow primary care has been completely left out in the nations. What we're trying to do is to basically build capacity, uh, pool resources to actually get a healthier Malaysia, right? But unfortunately, I think GPs and family medicine specialists in the private sector have not been engaged very well, because actually you are really it's like a untapped resource for cancer screening. Because unfortunately, we have been doing a lot of the like tumor markers and all that, and we've been doing it for decades. And therefore, that is why we are here today with the same scenario we have 30 years ago in terms of cancer staging. I'm sorry I didn't put up any slides about the National Cancer Registry reports, but I have to say it is still looking very dismal. So for example, for breast cancer detection rates for stage 3 and 4 is still about 50 over percent. And unfortunately, it's gone high, is higher than what it used to be in 2000, and I think the other report is in 2011. So the 2017 report, which is also a delayed type of reporting, as you know, it's not easy for them to get the data. They have one 2017 to 2022 that shows that the rates of stage 3 and 4 has climbed to 5% as compared to 48% in the previous cohort. So the same goes for colorectal and lung cancer. So colorectal cancer is worse. Stage 3 and 4 is about 80%. And for lung cancer, it's almost like 90 over percent will present with stage 4 cancers. So I think going back to our discussion about having symptoms or no symptoms, when we talk about screening, we are really talking to someone who is well, who has no symptoms at all. So I think the recognition of symptoms would be extremely important in the GP practice. We need to, because I think it's tough being GPs and family medicine specialists, because you see patients at the early part of the disease. They may not have much symptoms, but if they do, we need to actually get them onto the diagnostic processes as quickly as we can. We do have some what do you call it, benchmarks in terms of how soon a woman with breast cancer should be diagnosed. And currently, the evidence shows 60 days to be the cutoff point. So it's not a short time. 60 days is about 2 months. But if you look at how our processes go along, we see women presenting sometimes with a lump, and then by the time they get a mammogram, it's about maybe a month later. And then the mammogram is reported as dense breast, no lump seen. And then everybody forgets that she actually has a lump and should have had an ultrasound. And even if the ultrasound was normal, she still had a lump that needs to be investigated. So therefore, I think symptom recognition and knowing the next steps would be extremely important. And this is what we call early diagnosis. And WHO has actually have come up with their recommendations in terms of whether or not we should be doing screening in an upper middle income country. So in the upper middle income country, the focus on early diagnosis is extremely important, because once you sort out the diagnostic pathways, if you increase the screening methods, like for example mammogram and so forth, you have a ready diagnostic that works like clockwork, that can actually get these people diagnosed quickly. But if we start off with screening, we have now inundated our services with many mammograms, and all of them are actually quite well, and the poor woman with the lump may not be seen for a long time before she can get her mammogram and so forth. So that's why in the upper middle income countries, they are very, WHO has recommended that we do what we call early diagnosis. We get them, we recognize symptoms, we examine the patients, we find something, we refer, get them diagnosed as quickly as we can. So what do we do with those asymptomatic patients? We need to find the target population. We need to do risk assessment to assess what would be their risk. And then we can identify what are the screening tools. And even we may find existing subsidies. I think in Selangor nowadays, apparently, if they go into Sri Lanka, they can get free mammograms in private hospitals. And LPPKN have clinics around the country. The clinics are called Clinic No Sejahtera. They actually have a large an amount of money actually to be used for screening mammograms in the private sector. Okay. Okay, and the next one that all GPs, I think, will probably have your networks. I think all of you are quite otais lah, I would say, yeah. So I'm sure you know where to refer to if you find a patient with a symptom. And sometimes patient need to be also sort of prompted that they need to sort it out quickly, because some people may wait for GLs that may take months sometimes for some places. So we have to educate and maybe inform the patients that some things need to be expedited. But again, don't create fear, because a lot of our patients, I had a patient, remember I did a dissertation of why women present with advanced cancer. So this woman was very upset because she went to her GP and the GP looked crestfallen. So the GP was sort of knowing that I mean, most likely was a cancer because she had all the very late signs. But because of that crestfallen face, she was so scared, she never went forward for the next step. So I think we have to play also the role of a supporting person, to sort of give confidence to the patients. Because actually, I didn't share slides today, but survival from breast cancer, colorectal cancer is extremely higher now than what it used to be, especially if we detect them through screening. So I think having this type of supportive care during the treatments and diagnosis, and also when they come back after their treatments, would be extremely important for the GPs to have the tools and skills. Okay, sorry. Right. So I mean, okay, this came from ChatGPT. Not too bad. Okay, ChatGPT actually cut down a lot of my time, but honestly, what we think would be, I think ChatGPT also thinks so. GPs should be really involved, I think. This is for national interest, because unfortunately, I think the public sector is having a slow, I won't say it out loud, but it is not able to cope at all. What more with non-emergencies like cancer diagnosis or screening for cancer. So I think GPs play a massive role. And maybe we can discuss further later. How would you like to do it in your practice? Okay, so as I mentioned, we should define our target population. So now we know the age groups are actually the ones that gives us an indication of what to do for the patient. And maybe we can even encourage our patients to be self-managers. That means educate them what they need to do, like the same thing for diabetes, hypertension, and so forth. But we'll add on the screening for the cancers. Okay, and also knowing whether they have hepatitis B, whether they have family history, smoking history, obesity. All this will then give them some idea that, oh, okay, they are actually either average risk or at a higher risk, that they need to actually get their screening done accordingly. Okay, so these are all mainly data that if you want to do it in your practice, maybe you can see out of like women or men that come to your practice above the age of 50, do you recommend them this test? Okay, there's no tumor markers in here at all, but if you actually offer all this, how many would actually pick it up? Okay, and then maybe the reason why they're not picking it up, because sometimes maybe the costs. And I think this should be a national conversation rather than a Ministry of Health conversation, because they're always worried about not being able to fund the clinic kesihatan. But what if the patient could actually spend a little money in the private sector to make sure that they are doing preventive care? Right? So I'm not sure how it works in the GP practice, but maybe, like a Merpati Alliance, you're a group. Maybe you can actually do a lot of known volume ordering with the lab partners or kits, vendors, that you can actually bring the cost down. Maybe that's something you all would like to do, right? And are GPs, nurses trained for self-sampling, fit counseling? All this could actually be done. And then do you have some system that helps you recall patients when it's abnormal, right? And do you have clear referral pathways to hospitals in the private sector and also in the public sector, especially for those who are of the lower income? And we must also make sure equity. I think equity is not just the responsibility of the Ministry of Health. Sometimes they're just beyond capacity. So how do we as, citizens actually try to be inclusive and ensuring that people who are of the lower income and, also maybe they are too far away from hospitals get the treatments or screening that they need? So I'm not going to go into that. Action plan tadi itulah, you ask ChatGPT, they give you everything. You can do something like this as a group maybe, and show it that, that people in private sector, you're also serious about citizenship and citizen health, right? To show that you are actually doing screening. Because at the moment, I think we're not doing it as a whole. We just, it's very hopscotch everywhere. It's just like, it's not concentrated, it's not coordinated. So how do we show impact? So maybe this is something that maybe Merpati wants to take on as something that they want to bring forward, right? So this is just again from ChatGPT, what you would do to actually improve your apa ni? To show impact in your practice, right? Okay, so now I go to the WHO best buys. So there was the 2023 policy document from WHO that says what are the things that they would recommend, especially to lower income and middle income countries. So these are all evidence-based in terms of health economy. So it does have it makes sense to do this, and it has good what do you call this? Health economics implications, right? Okay, so HPV vaccination. So tick, we do that in Malaysia. Hepatitis B immunization, tick, we also do that. Screening and early detection. So cervical cancer screening. So there are a lot of offers from the Ministry of Health, Klinik Kesihatan, as well as Klinik Nur Sejahtera from the Women's Ministry of Women's and Family Development. So they do have this, but is it really promising coverage? Okay, so coverage may be a problem. So I think they are doing something, and you will probably see it on My Sejahtera soon. So there is a banner on where to get screened in the Ministry of Health. Okay, so they are trying to do something about that. Okay, then remember we talked about early diagnosis. You see, in the WHO Best Buy, they don't even suggest we do screening mammograms. Okay, but then we are upper middle income country, and we do offer opportunistic screening. So I think if the patient can pay or there are subsidies available, we should use it as it is, if we can, right? But they have suggested early diagnosis, which is really getting people who have symptoms through early and timely diagnosis. This is mainly for breast, colorectal, and liver cancers, right? All right, and then treatment follow-up, what they expect us to do is integrated care for cancer patients. That means actually integrated care in the West and in a lot of the public sector mind is primary care. So that means the involvement of primary care in survivorship care, taking care of people post-cancer treatments. That means taking care of their cardiac health, taking care of their lifestyle choices. That should be really integrated with primary care. But in Malaysia, it's a little bit difficult. I think we have lost that connection somehow. Yeah, so this is something that we should also work with people in the private sector. All right, so I think at the moment we have the HPV self-sampling, we have the expanded fecal immuno test based colorectal screening in some of the Klinik Kesihatan, and I've seen some of the private labs also offering it in the pharmacies as self-testing kits, okay, that they have some data, but I don't think it is really evidence-based, but people are still trying to fill up the gaps in this way, okay? So I think this is something that maybe as a group, Merpati can look into how you can actually offer this. Imagine if a patient pays for tumor marker 600 ringgit a year, and the FIT actually costs less than 100 ringgit. Maybe then we should really make it worthwhile for the patient, because this is evidence-based, okay? Then we must strengthen linkages from primary care to specialist referral. We have to enhance our data system so that we can monitor and know whether we are reaching our targets in terms of early diagnosis. And the coordination really, I think, is the issue. We have had 3 policy documents from the Ministry of Health for National Cancer Control Strategic Program, they call it NCCSP. And this policy, there's 3 editions, all right? And 3 editions after that, some stages are getting worse, for example, breast cancer, and we are not moving the needle at all. So the implementation part, and I think engaging with the private sector would be extremely important. Okay, so this one I just show it again, but I don't think I need to go through it again. So in conclusion, uh, we should actually look at cancer screening, and you should look at your uptake and then see how we can improve that in the private sector. We have to integrate and promote self-management for the patients, because honestly, it would be better for the patients to know exactly what they need to do. Okay. And then we can work with partners, look for subsidized screening, LPPK, and again, as I mentioned, and again, if there is a positive screen or a patient with symptoms, you can actually provide that navigation to the care pathways. So a little bit of information, because I think a lot of people are not aware. So for example, in PPUM, we are known as the expensive public hospital, which is true. But at the moment, we have funding for diagnostic procedures. So in the past, our funding subsidy and funding, welfare funding is for treatments and not diagnosis. So from 2005, we have been working hard to see how we can close this gap. And in 2017, we got some money from Avon to pay for diagnostics. And over the years, the team, I'm actually retired now, but the team actually raised funds. Every year they would do runs and all that. And that money actually goes into this. So our latest funder is from Pink Ribbon Wellness Foundation, and they have donated about 100,000, if I'm not mistaken, for diagnostic procedures. So please refer. I can send this blip to Dr. Nasir and Dr. Ganesan so that you can get this information. You can contact the Pusat Sumber Kanser Payudara in PPUM to get them to see how we can access this subsidy. Okay. The other resource that is available in the Ministry of Health is with the collaboration of Cancer Research Malaysia and Ministry of Health. They have pink ribbon centers set up around the country. And in Selangor, it's in Hospital Selayang, Ampang, Kajang, Sungai Buloh, Tanjung Karang, and Hospital Tuanku Rahimah Kelang, and also Hospital Putrajaya. So if you have a patient who you think may have cancer, for a diagnostic, it's actually free. Well, not free, like almost free in the Ministry of Health hospitals. Please look out for them. Pink Ribbon Center, you can go to the Cancer Research Malaysia website and see how you can contact them, because these hospitals, this Ministry of Health hospital, have very good coordinated centers. We call it Pink Ribbon Center. So all people who do breast surgery have got what we call resource centers to sort of coordinate care and look for subsidy for patients. The last one I would like to mention is the Rebong Cancer Care in Primary Care short course that is running, I think, in its third edition this year. It's made up of about 5 weeks of online classes, and we also do 2 echo sessions. The first will be the opening, and this time we did for colorectal cancer. So what happens is that the people who undergo the course, they are given some information, and then usually we come up with some cases to discuss in the opening, and then we teach the participants how to use the online platform. And then we do a closing at the end of the course with another discussion. And again, the people who present are actually the GPs who underwent the training. So cases are discussed, and then we bring experts for discussion. So the next edition will be next year. It will be in March. So do contact us if anyone would like to do this training. So what we have is training modules on breast, colorectal, lung, cervical, prostate, psychosocial aspects, as well as navigation of patients. And we also support the trainees with the echoes. So this cancer echo is actually part of that growing group of people interested in making a change in Malaysia. We have to really downstage our patients. And actually, we do have the tools. It's just that how do we coordinate it to make it better? So with that, that was actually my last slide. So thank you very much. Maybe now we can discuss and have a good discussion. Okay, thank you. Dr. Ganesh, I'll pass it back to you.
Thanks, Prof. Raisha. It was a wonderful presentation and a lot of inputs for GPs. Uh, there's a lot of things for us to catch up today from what you have said. Okay, thanks a lot. And going through the question Q&A, we see there is Ms. Louise Nathaniel. Dr. Louise Nathaniel has asked how accurate is nasopharyngeal cancer screening. That's one of the questions that he has posed for us.
Okay. I mean, I'm not an ENT surgeon, okay? So NPC is not something actually being highlighted as a policy, but there is a very active group looking into NPC. So they do have training in identifying oral cancers and all that. But NPC screening, as you know, it is related to infections. So whether or not, I don't think there is really a infection screening test like HPV test that they do for cervical cancers. So maybe I should stop there because I don't know. I think what we could do in the future, if there's a lot of interest in ENT cancers, we can bring this up to the Cancer Eye Echo Committee so that we can have another sort of CME looking into ENT and head and neck cancers. Okay, I hope that's okay, Dr. Ganison.
Yeah, sure. I think the ear, nose, and throat specialists, they would be involved in this. That's a good one. Yeah. And then is there any role for screening lung cancer with early CDT lung autoantibodies to TAAs? That's another question from Hazeme.
Yeah, so lung cancer screening, I think right now the evidence, which is also divided, is on the low dose CT scans and probably also in the future, after that gallery study is published in 2026, maybe there will be some role of the genomic type of screening, looking at circulating DNA and all this. But whether or not the antibodies to what you were saying, I am not sure. I'm not a lung physician. As far as I know from what we have put in our discussion, we have had like Professor Pang, who also did one of the sessions with us, I think maybe last year or 2 years ago, which is recorded, by the way. You can actually get our recordings for this type of discussion on the Cancer Eye Echo on, I think it's the YouTube Rebong, no, I think it's the Breast Cancer Resource Center UMMC YouTube channel. You can find a lot of our discussion, and there was one on lung cancer specifically. So the thing about lung cancer screening is that we have a high prevalence of TB. So when we do even low dose CT scan, what we might find is a lot of false positives. And the next steps of diagnosing a lung cancer is actually a biopsy, which is access may be a big problem and quite expensive also in the private sector. But that should not stop you from screening a high-risk individual. So for example, someone who is a heavy smoker, there are actually specific criteria for whom is high risk that you can offer lung cancer screening with a low dose CT. So if you ask Professor Pang, we don't routinely screen in the public sector because of that, of what we mentioned just now, the high false positive rates that require a proper CT and biopsy of those lesions. But in the private sector, especially in high-risk individuals, I think why not? Because lung cancer is almost is quite bad if it's diagnosed very late. But again, lung cancer now has a lot of these targeted therapies that may work, and it's actually oral, very good quality of life. It may extend their life for quite some time. So I would say if you have a patient who is symptomatic, I think the worst thing is that people who are symptomatic may actually oh. Shahira, can you help the videos? So the videos you can shut it off, yeah? Right. Okay, so where were we? Lung cancer screening. So lung cancer screening, No, I think the antibodies have no role at the moment. Watch out for the space next year for the Gallery trial from the UK that looks into this multi genomic studies, screening studies for multi-cancer panel. You know, it's a multi-cancer gene panel to test for multiple types of cancer, but the results are only out next year. Okay,
Thank you, Prof, for
all
that.
right.
And there are another couple of more questions there.
Okay.
Can we say the blood screening test like CA125 is not to be used for screening, but more for looking at the worsening of prognosis with treatment?
Yes.
And then a follow-up question to that is, since CT scan nowadays already low dose, do we need to specify low dose nowadays?
Oh, okay. I think the low dose is very specific for the lung cancer protocol. So for CT scans, they have different protocols when they do it. So not necessarily other protocols are low dose. So I think at the moment it's only for lung cancer that we know of, but for others, not really. So that I don't think we can order for low dose, let's say thorax, abdomen, pelvis, and things like that. So it's specific for the lungs.
Okay, then hi, Prof. Aisha, what is your take on ultra-portable handheld breast exam for breast cancer screening, especially for rural areas with lack to access to mammography?
Okay.
The lack of access to mammogram, basically, yeah.
What is the name of the test? Did they say? I can't see the chat box. Unfortunately, I can't find it.
Hi, Prof.
No, no.
Aisha.
Hi.
Hi. The name of the test is Ultra Portable Handheld Breast Exam, something like Breast Exam Gen 1 sensor technology. I've just read about it. There's
Oh,
a pamphlet. Yeah.
okay.
I'm not sure if you're familiar.
Okay, there are many, many of these types of devices that unfortunately, I think it depends on the setting that we're practicing. So I think there are some like the one called iBreast, which use like electrical impedance to create like to know, whether
Yes, it's iBreast, Doctor, correct.
yeah, breast. Okay, all right. So we must always fall back on what is the cost effectiveness of doing these things. Okay. So that eye breast actually improves sensitivity of a breast examination done by a non-specialist. So that is what eye breast is for. So it's to help someone to improve their specificity and sensitivity of the breast examination. So that is usually done in scenarios where there's no mammogram available, in the low resource setting, low income setting. So what we as a national task force, I think we all sat down. I'm actually one of the members in that task force to sort of look into all these different modalities. So we know that eyebreast may actually add a layer of complexity where we have not even sorted out the standard of care. So the standard of care is for screening, there are two methods. One is clinical breast examination, and the other one is mammogram. So these are the only two evidence-based screening for breast cancer. So the examination of a woman can be done by a nurse or a doctor. And of course, this type of examination is better when you have more experience, right? And exposure to diseases. So what we suggest now is that we cannot include eye breast into this complexity because what usually happens with it is that it increases the use of other tests. So for example, ultrasounds. So what we see I think they did a pilot somewhere in Sabah or Sarawak. They've got the NGOs to go out into the rural areas and they did the eye breast for free. But unfortunately, when the woman had to do ultrasound, they had to bring her right down up to the city centers to actually get the ultrasound. And nobody is paying for the ultrasound. So it adds on another complexity to this. So I would not suggest we add on another complexity in our already a bit messed up lah. The standard of care is there, but it's not well coordinated. That is why I think the Ministry of Health is very focused now. They are actually making sure the centers are to people. So for example, I talked to you about the pink ribbon centers. Once the patient enters into that system, the mammogram ultrasound biopsy is done, could be done within the same day or within the same week. someone is navigating the patient in the hospital system to make sure everything is done in a timely way. So if, let's say, GPs, I think one of the things that might be useful is improving your clinical breast examination competency. So that is something that I guess is through experience and maybe through training again, just to make sure, because what we're trying to find are the 1 to 2 centimeter lumps. When we examine the patient, we cannot do examination by quadrants. We have to use either the strip method, that means we go up and down the chest in small circles, like you're trying to not miss that 1 centimeter lump, okay? Or you can do a radial method, like you go from the outer quadrant to the nipple in a very systematic small strip area that you cover. So I would say if a doctor could do the clinical breast examination every 2 years, it has been shown in India, and this is run by community nurses, not even like at the surgical clinic or something like that. It's actually run by the community nurses, and they found that mortality is reduced tremendously, especially after the age of 50. So I don't suggest you get on the eye breast lah. It's too complicated in a sense that you will need to do another test eventually. You know, you might need to get an ultrasound or a mammogram after that. So rather than having all these complexities, why not just stick to the standard of care? Any woman above 50 especially, if they are of average risk, 2 yearly mammograms. And if they have dense breasts, make sure they get on to do the 3D mammograms rather than the 2D mammograms. And if they have very dense breast, and ultrasound, supplementary ultrasound would be useful. Okay, I hope that answer your question. Because
Yes, you did. Thank you.
actually, you realize that Malaysia is a fantastic market, okay? 30% of our healthcare is paid for out of pocket from the patient. So in a sense that we have a rich community. So all the businesses want to come here. So we have seen all kinds of machines coming through our doors, promising the ultimate no pressure lah on the mammogram and all that. But we are looking at newer technology. Actually, there's another technology coming out, and it's actually available in Germany, and slowly it's getting recognition. This is what we call CT mammogram. So it uses CT scan, like the spiral CT scan, but it takes images of the breast, and the dose of the radiation is similar to a mammogram. So we're quite excited to wait to see how we get this type of technology into Malaysia, because it is similar, it's an imaging, it is using the same radiation dose as a mammogram, and it is going to give you no compression. Women do not like compression from the mammogram. So this is a very good tool, I guess, for people who do not want to have compression. Oh, the
Thank
other
you,
thing
Prof.
I noticed is ultrasound in the primary care setting. So I think ultrasound has become our extension of our hands. Actually, I use ultrasound a lot in my own clinic. But I think it's very important that we are very clear about what we see. Because even today, I was seeing a patient today. She is the high-risk woman. Her father had prostate cancer, her aunt had breast cancer, and another uncle had prostate cancer. So she's high risk, and she had a lump in the left breast. So what happened was she went to a GP. The GP did an ultrasound for her and put it as a BI-RADS 3. BI-RADS 3 means it's benign finding. So I think when a lot of times when we deal with people who are high risk, even benign looking lesions need to be biopsied, because a lot of this family history type of cancers, for example, the BRCA1 carrier with the medullary cancer, the tumor looks like a fibroadenoma on the ultrasound. So it is extremely important that even though the ultrasonographer, and I think it's not a radiologist, it's an ultrasonographer and maybe an MBBS sonographer who reported it, knows what they're doing, because they can cause a lot of harm. So this lady, basically, she came to me for a second opinion because she did her ultrasound in the clinic. was told that it's a Birex 3. She just needs to have another test in 6 months' time. But she got worried. So she went to Hospital Sungai Buloh, had an ultrasound, and the radiologist reported it as a Birex 4B that needs a biopsy. So then she got scared, why is it different? Only a period. And she didn't even wait 6 months. She waited only about 3 months and she got the ultrasound. So that's why I think it's we have all these tools, but we must use it in the way it's supposed to be used. And I would be very worried in the future where our patients are so litigious. If something is reported as benign when actually it's not, it becomes a very, and it might go to court and things like that. So I think people out there who have ultrasound, you can use it, but you must always add the caveat that, they need a proper examination by a radiologist and a referral to a breast surgeon. Okay, I think now we should say just breast surgeon. In the past, we say, okay, general surgeon also, but now we have so many breast surgeons. It's important that the breast surgeon evaluates the patient because this patient actually had a lump. It was not screening, and she should have had a biopsy 3 months ago. Okay? But actually, all this information that I told you is actually in the course. So the course will teach you about symptoms, no symptoms, what sort of screening protocols you should do, and how to interpret the reports of the radiologists, and how to do a risk assessment. So that is all in the course that I mentioned just now. Okay. I hope that
Thank you,
answers your
Prof.
question. Okay.
Okay, due to want of
Time.
time, actually, we just take one last question.
Okay.
There's Hugh Ping Lau has asked, Prof, can you explain about, or so rather expand FIT for colorectal cancer?
Okay.
And
Okay, I think there are many ways of doing IFOBT. So last time it used to be called fecal occult blood test. They use the guyak base test where the patient cannot take any iron for don't know how long, right? But that one you don't need it anymore. So now it's all is immune based test. So that means they have antibodies towards the blood actually. So it doesn't measure iron content and all that. So that is what is commonly available. But there is another test that is DNA based. And this DNA is shared by the shared by the tumor into the stool, and that actually can be detected by this test. So it's almost like a DNA test of the stool. I think it's quite expensive. I'm not sure how much it costs. And again, I think what you can do is to listen to the YouTube channel that I mentioned just now. We have one on colorectal cancer that was discussed. The discussant was siapa nama tu? Prof Tak Kun Prof Tak. No, Prof Kun Tak Lun. Okay, I know him as Tak, but his name is Prof Kun. You can listen more to his explanation, and we also have another one by Dr. Gerard. He used to be with Ministry of Health, Datuk Fitzgerald from Hospital Putrajaya, if I'm not mistaken. But he's now retired, but he's a colorectal surgeon, and they also discuss about this. So maybe that will help you more because I'm not a colorectal surgeon, unfortunately.
okay,
Okay.
that was the last question. And thanks a lot, Prof. We are indeed very delighted to have you here and a lot of information on this excellent Saturday evening. And there's a QR code for all those who are, you basically can scan the QR code and you get your CPD points for the day. And again, Prof, thank you. And we are looking forward to see you more in our MAG programs with various other more related probably to breast cancer. And I think in more detail approach, that will be great. And again, uh, from the bottom of the heart, thanks a lot, Prof. On behalf
Okay.
of MAG and on behalf of MHSBV, thank you a lot.
Okay, thank
Thanks
you,
a lot.
Harrison. Maybe a photo. I think Shahira has to take a photo for recording purposes.
Okay.
Shahira, do tell us what to do, yeah?
Okay. Prof can stop presenting.
Okay, where is it? Share, stop share. Okay. All right.
May I check if everyone got to scan the QR for CPD point just now?
I have to say 173 participants is amazing. Thank you. I think it's a very good reach that you have with your group. And
We
what's the act for what Doctor Forever? What is that? I was very keen to know what is the Doctor
Okay.
Forever.
Doctor for Ava is actually that was the initial group, which was a WhatsApp group started by the PJ community for the PJ doctors. Actually, that
Oh,
is they were discussing like during the COVID period. Basically, they were discussing cases amongst themselves, and they were helping each other during that very difficult period.
okay,
And it started from there when they started to discuss cases one by one. The GP set up this particular
okay,
patient came here, this, and they started. And from there, the CME actually, we found out that Dr. Nazir Low, he's the person in charge for the Dr. Forever for the CME. And there are a few family medical specialists as well. And all of them together, they started. And that, in a course of time, went to 700 and 800 doctors joined Dr. Forever because they wanted to see what the CME going on. It was, there were no points, nothing, just between ourselves. And
okay,
from there, we've actually come to this situation where we wanted a CME program from a specialist. And we're also looking forward to our WhatsApp, what do you call the talks, whether we will be able to get some CPD points as well. We have been discussing that with the authorities, and then I think we should be able to get that very soon.
okay. Thank you. Well done lah.
Uh,
I think we
uh,
have. I think must be the orang PJ lah.
that community is
Memang
really good.
memang memang orang PJ pun
Orang
Prof.
PJ kan. Itulah. Ah,
Orang PJ yang buat kerja ni.
kan. Bagus, bagus.
Ya.
Okay. Okay, Syairah, kita nak ambil gambar kan? Okay, Syairah, what do we do? Everybody put on your videos. So you can see it's multi-generational lah. Not bad lah you all. Okay. Put on your videos.
Yeah,
Syahira
open
ambilkan
video.
eh?
Yep,
Okay.
okay.
Syahira is our power woman lah. She's the behind the scenes from the UMCRI side. Thanks, Syahira.
Yeah, thank you, Shaira.
Okay, I'm taking it now, so wait
Okay.
check one. Okay. Okay, 1, 2, 3. Okay. The one.
Okay. I think you have 4
Okay.
pages. Okay. Dah.
So, okay.
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 All right.
Dah siap ke?
Okay.
Dah. Okay. Thanks, Syahira. Okay. Thank you,
Okay.
everybody. Okay.
Yeah,
Have a good
thanks, Prof,
weekend.
and thanks,
Bye.
Shaira. Yeah,
Thank you.
Okay.
thank you
Thank you,
so
Dr.
much.
Nasir. Bye-bye.
Okay.
Dr. Garrison.
Thanks,
Bye.
Dr. Nazir.
Okay.
Thank you, Prof, and thank you, Ganesan.
Yeah,
Prof,
thanks.
your talk was very good. I think we have a very good turnout today. We have nearly about 20% of our members that turn up.
Okay.
The last couple of our CMEs, we have less than 5% that turn out.
Mm.
So, yeah.
Yeah, we can
This
do
week
more
we had
lah.
like
We can call the
195 people
other,
or so. Yeah.
we can
Yeah.
call the other experts, colorectal, lung, or ENT. We can get from UM or our other private doctors. Yeah. Okay,
Yeah.
thanks. Okay, goodbye.
Okay.
Thank
All
you.